On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Dr. Alan Zacharias and Dr. Srini Iyengar. Dr. Zacharias is board certified in neurology with added specializations in clinical neurophysiology and electrodiagnostic medicine. He received his medical degree from the University of Mississippi and completed his neurology residency at the University of Virginia. He then completed a fellowship in electromyography and neuromuscular disease at Emory University. Some of the most common conditions Dr. Zacharias treats are migraine headaches, stroke, memory loss, dizziness, multiple sclerosis, seizures, Parkinson's disease, and peripheral neuropathy. He sees patients at Associated Neurologists in Boulder. Dr. Iyengar is a board-certified cardiologist who is fellowship trained in cardiovascular medicine and interventional cardiology. He attended medical school at Ross University with subsequent internal medical training, including a year as chief resident at the Jewish Hospital, University of Cincinnati. He then completed a heart failure and transplantation fellowship and a general cardiology fellowship at the Ohio State University. This was followed by a 2-year advanced interventional cardiology and peripheral vascular fellowship at Columbia University. Dr. Iyengar leads the structural heart healthcare program at Boulder Community Health and sees patients at Boulder Heart. Welcome to our speakers.
Good evening. Thank you for tuning in. This is a topic I think we can all easily get behind, and that's reducing your risk of stroke, one of the most feared complications of medical illness. And I'm going to begin this lecture talking about some risk factors and some epidemiology about stroke, and hopefully hit on some of the topics and questions you guys may have for us. And Dr. Iyengar will then give us some more advanced knowledge about the important role of the heart in stroke. One of the things we're seeking is to obviously stop stroke. We use words primary and secondary to refer to strokes that are due to predominantly vascular disease or secondary causes that might come from external factors, and that can be like a problem within the heart. One of our acronyms is FAST, also often even longer, be fast, to include some of the symptoms to think about anytime someone has a change in either their face, their arm, their speech, and the T stands for time. If you add in the B part, that's BE, we're referring to balance or any eye findings. So try to think of that acronym anytime you're under duress and trying to help assess whether a family member might be having a problem. And we want to spread the hope about recovery. There are great opportunities to help you if you have an acute event, and great opportunities to prevent future strokes. You're going to learn a lot about that tonight. We want to reduce the risk of strokes, we want to recognize the symptoms, and we want to always emphasize, no longer should you sit around and wait to see what happens. Take it seriously, call 911. That's our best chance to help you, and the time matters. It's a leading cause of death in the United States. Nearly 800,000 Americans suffer a stroke each year, 134,000 deaths or more. From 1996 to 2006, the stroke death rate fell 33%, and the number of deaths fell by 18%. We are really making progress. But there are over 6 million survivors of stroke, major impact. It's the leading cause of disability in adults. Up to 80% of all strokes are preventable, though, through the risk factor management. On average, someone has a stroke about every 40 seconds. As you can imagine, emergency rooms are very busy places trying to assess this condition. It kills more than twice as many American women every year as breast cancer. More women than men die from stroke, and the risk is higher for women due to a higher life expectancy. Women suffer greater disability after stroke than men, and women aged 45 to 54 are experiencing a stroke surge. This is thought to be due to increased risk factors that include obesity, high blood pressure, high cholesterol, and sometimes not recognizing that women can actually have a stroke just as men can, and even at higher rates in some age groups. In ethnic groups, there are variations. In the African American population, it's nearly double the rate of stroke than the Caucasian population. More physical damage is common, twice as likely to die from stroke, and higher incidence of some of the risk factors. That's high blood pressure, diabetes, obesity, smoking, and sickle cell anemia, a unique condition among African American populations. In the Hispanic population is also higher than the Caucasian population. Increased risk for all types of stroke, and TIA. TIA is our abbreviation for a warning for a stroke. It stands for a transient ischemic attack, and the word ischemic means loss of blood flow. It can often happen at a younger age in the Hispanic population. And just having a language barrier often means lack of knowledge about these topics. We're trying to do better with our education in all groups. Some common, well-known survivors of stroke. Many have been added since that time, but most of you probably recognize many of these names. What is a stroke? Well, it's sudden damage to the brain. It's a lack of blood flow to the brain caused by a clot or a rupture of a blood vessel. The ischemic portion is the equivalent of saying there has been some form of clot, and that's about 87% of all strokes. Hemorrhagic is the word equivalent to saying bleeding. It's bleeding around the brain or within the brain. This is a picture showing the carotid artery that is normal on the left side, and on the right side of your picture, that's showing the plaque buildup that's blocking what's called the internal carotid artery. That is one of your risk factors that you're trying to reduce. It takes decades to build up this plaque, so what we start even in our youth matters, unfortunately, much later in life. It's one of those silent killers that builds up until a catastrophic event, and we want to talk about how to prevent this from happening. Stroke symptoms are characterized by sudden onset. It's usually a severe deficit from the start, though it can be quite variable. There might be headache, you could have trouble with vision, dizzy, trouble walking, confusion, speaking, numbness, and it tends to be on one side. It isn't always, but usually it's one-sided. Our anatomy is crossed. Left side controls the right, right side controls the left. Not absolutely the case, but very common that it's that way. There's that acronym I mentioned earlier. Check the face, the arm, the speech, and do it quickly, and don't delay. Call 911 when you're not sure if this person might be having a stroke. Every minute matters. Millions of neurons are saved the faster you get someone in. That's the TIA definition again. This is the temporary ischemic attack, transient event. It's a warning sign that you might be about to have a stroke, and up to 40% of people who have a TIA will have a stroke in the future. Your greatest risk after a TIA is that first 12 to 24 hours. That's why we like people to come in. We usually admit you if you come to the hospital to do a quick evaluation. These symptoms can resolve in just a few minutes or several hours. Pretty variable. But the quicker you get in, the quicker chance we have of finding the source. There are a couple of myths versus reality to talk about. The myth is that stroke is not preventable, that it can't be treated. It only strikes the elderly. It happens in the heart, and that stroke recovery stops after 6 months. In reality, up to 80% of strokes are preventable. Stroke requires emergency treatment. You don't want to delay. And anybody can have a stroke, from a child to an elderly individual to a pregnant woman or anyone in between. Unfortunately, it can get any of us, and it can be a real surprise. We think of it as a brain attack. Heart attack is a cardiac problem, brain attack is a brain problem. And the stroke recovery can be nearly lifelong. Patients continue to improve many, many years after their initial stroke. So you don't give up hope. Incredibly expensive to the country and productivity. $73 billion, that was in 2010. The lifetime cost for somebody, over $140,000. You want to follow guidelines to reduce your stroke risk. You need to know what your blood pressure is. Have it checked at least once a year. Everyone should have a primary care doctor. Everyone should periodically check their blood pressure. Find out if you have atrial fibrillation. That's going to come with basic screening of symptoms as well as what's called an EKG. It can catch rhythm disturbances. Your doctor will help you manage that. If you smoke, by all means, please stop. It's a great risk factor for developing vascular disease, and that can cause heart attacks and strokes. If you do drink alcohol, do so in moderation. People often ask me, well, how much can I drink? Average recommendation, 1 drink for a woman, 2 drinks for a man, standard size drinks, 1 beer, a couple of ounces of spirits, or 6 ounces of wine. It's good to know what your cholesterol number is. If it's high, there are guidelines your doctor will work through to help you decide if you should just modify diet, increase your exercise, or perhaps you need a medication. If you have diabetes, you want good control of your blood sugar. Many ways to do that these days. Exercise every day. Typically, we're saying 30 minutes per day of reasonable exercise. It doesn't have to be heavy exertion. It's get out there and do something. Lower salt diet, lower fat diet. We're talking basically about the Mediterranean-based diet. That's the one that has the best evidence for protection for cardiovascular disease. If you have problems with your circulation, keep working with your doctor to come up with strategies to minimize that impairment. And again, call 911 if you're having symptoms that might be a stroke. Why don't people come to the hospital on time, or why might someone miss a stroke? Well, we might not recognize the symptoms, and denial is powerful. Oh, it'll go away. It's probably not a stroke. Maybe I'm just tired. We hear everything, and we're all, including physicians, maybe more so, we are guilty of not facing reality. You need to take it seriously. You need to seek out help. You might think nothing can be done. I promise you, a lot can be done. Major changes have occurred in the last decade. Cost, very real. Everything is expensive. People worry about that. That's a reason not to come in. But think about the cost of not coming in and the consequences of a severe impairment. You might think symptoms will go away. Well, they might, but then that would be probably a TIA. And remember, you have a high risk of a stroke within 24 hours after a TIA. And some people aren't very trustworthy of the system. We hate to hear that, and we are always trying to keep you trusting us. But we have one agenda, and that's to help you get through any acute medical event. Again, this is a blood clot condition, and what could you do to treat an ischemic or blood clot condition? We can help destroy that clot with a medicine called TPA. Sometimes it's given by vein, sometimes it's given through a catheter, and there are time windows in which you can get that. It used to be that we would say you had 3.5 hours. Then we said, no, you have maybe 4.5 hours. Now, in the last few years, studies have shown you might have up to 24 hours to be a candidate for an intervention. And that is absolutely encouraging for all of us. Even if you wake up with a stroke, we're starting to get data to say some patients might be candidates for reversing that deficit. It's a wonderful time in terms of opportunity for treatment and interventions. You can help relieve the clot by taking it out with these devices. These are devices that can go into a vessel and pull out the clot or suck out the clot tissue. It is the standard of care. If you have a large blocked vessel, we will try to get that out. Hemorrhagic stroke is different. You don't use blood thinners in the setting of a hemorrhage or bleeding. If you have an aneurysm, which is a blood vessel defect that might rupture, That could be closed by a neurosurgeon, or a catheter might be placed up into the vessel to coil it. Coil it meaning putting in little coils of metal that close off that little aneurysm and keep it from rupturing again. A lot of opportunities for intervention. What about recovery? Well, some people almost completely recover, maybe 10%, 25% mild deficits left over, about 40% have moderate to severe impairments, and then 10% lifelong need for care in a special facility, about 15% risk of death after a stroke, very much dependent upon your age and other general health. The way we help you recover is with physical therapy, occupational therapy, speech therapy, and recreational therapy, doing what you can to get back to a high quality of life again. These are the changes that occur for survivors and the caregivers after stroke. Long list of different impacts, and I won't read all of those, but it affects so much of your life, from physical to personal life and mood and what happens to those around you. They're impacted as well. They may have to become lifelong caregivers. Many different forms of recovery therapy is available, whether you go into a facility and stay for days or weeks at a time. You may have home therapy, and then a lot of outpatient opportunities for treatment, and then community-based programs are there to help you in the longer-term recovery phases. The National Stroke Association focuses on ways to try to reduce the incidence and impact of stroke, to advocate to get interventions more public funding and education about this, provide professional education, keep your physicians and providers up to date on the latest information, and talk about the resources available to you when you're trying to get through this, whether you're a survivor of the stroke or one of the caregivers. They're there to help. The American Heart Association and also the American Stroke Association have similar missions. That's a contact information. So I'm going to hand over to Dr. Iyengar to talk to you more about the cardiac aspects of stroke. Thanks for listening to my part of the presentation.
Thanks, Alan. Well, thanks, Alan, for that great introduction on stroke and basically the mechanics of stroke. And now we're going to go quickly into where some of these clots may originate from. So stroke straight from the heart. So what causes stroke? So a number of things can cause it. So emboli, or basically clot, little tiny pieces of clot, can come from the heart valves or from the left ventricle. It can come from the carotid arteries or the aortic arch. You can get bleeding, as Dr. Zacharias mentioned, and AFib, which is arrhythmia that can cause clot development in a part of the heart called the appendage. And then there's other parts of the heart that are basically doorways for stroke called PFOs, which we'll talk about as we go on. And of course, the one that no one likes to address because it really doesn't have a lot of therapy when it comes to mechanical devices, but actually is probably the most prevalent, is hypertension, getting your blood pressure down, treating it with medications or diet and exercise. These are things, though, that can actually prevent a stroke from occurring. So again, what are sources of cardiogenic emboli? So again, we're going to mention in the top left, you see the paradoxal emboli, which can come from a hole in the heart. You have the mitral valve, which if it's infected can have a little bit of vegetations or infections on it that can go to your brain. You have the left atrium in the top right corner, whereas atrial fibrillation can cause clot development in the appendage. You have the aortic valve, which has calcium on it, which can embolize after it breaks off. And if you've had a heart attack or a weak heart muscle, that big sac on the bottom called the left ventricle can accumulate clot as well. So atrial fibrillation is an irregular heart rhythm. Basically, the top part of your heart, the atria, don't communicate electrically with the bottom. So what you have is basically the bottom part of your heart beating, trying to pump blood out of the heart to the rest of the body, while the top part of the heart basically quivers or doesn't really move much. So what does that result in? Well, AFib results in shortness of breath, lightheadedness, palpitations, but can also result in other things like stroke. And that is something that obviously is really important to know if we basically have a heart arrhythmia to get checked out. And only an EKG can truly diagnose it. An irregular pulse can be a number of things. So what causes this issue? High blood pressure, heart attacks, coronary disease, abnormal heart valves, heart defects you're born with, an overactive thyroid gland, or exposure to excessive amounts of caffeine, tobacco, and alcohol. So the diagnosis of atrial fibrillation, you need an ECG, EKG. They're same things, ECG, EKG, same test, because not every irregular heart rhythm is AFib. PVCs, APCs, these just mean extra beats, can basically mimic atrial fibrillation, the feelings of it, because it causes an extra beat and a skip beat, and you may think you are in AFib. So AFib does not have to be chronic. It can be short-lasting or come and go. So don't think just because you're in a normal rhythm that you could not have had AFib an hour earlier when you felt the palpitations. What's the treatment for AFib? Medications to control the heart rate, like beta blockers, calcium channel blockers, antiarrhythmic medications can be used. Cardioversion, which means we electrically or chemically convert you from AFib back to normal rhythm. Or specifically for more long-term patients, we perform something called ablation. And our electrophysiology colleagues at Boulder Heart perform this, where they go in and actually ablate the pathway. And this can be done surgically as well, especially if you're undergoing an open heart procedure, the surgeons can perform an ablation as well. So what else does AFib cause? Stroke. The left atrial appendage is in the left atrium and can collect blood, which forms clots that can break free in patients with AF. That's why we place patients with AF who have elevated risk for stroke on blood thinners. So when you see the commercials for somebody playing out in the yard and they say, because of this blood thinner, this person has a quality of life. Well, that's because the blood thinner is treating the possibility of stroke development with this rhythm. It has no bearing on atrial fibrillation. So if you say, well, I want to get rid of my atrial fibrillation, that's why I'm taking Eliquis, those are independent factors. Atrial fibrillation, the rhythm, can be treated with other methods. However, the clot development due to atrial fibrillation needs to be treated with the blood thinner. So the blood thinners work very well as long as you take them. And that sounds simple, but it's very hard to do. Sometimes patients will say, oh, I took my meds yesterday, but I think I forgot the morning dose today. The blood thinners are usually 24-hour medications or 12-hour medications. If you forget a dose, there's a chance you may actually not be protected. If you're taking something called Coumadin or warfarin, that medication has to be strictly regulated. So missing a dose or taking too much of a dose can put you up or down on the curve, whether it be high risk for bleeding or not effective. So again, you have the generic warfarin Coumadin medication, and you also have something called the NOACs or DOACs, which are the Eliquis, Xarelto, Pradaxas. You've seen the commercials for these medications. The problem with these medications, of course, are the cost. A lot of insurance companies won't cover them. And it's, again, as a blood thinner. So you have to understand that taking these medications, there is a higher risk of potentially developing a worsening bleed, especially if you have an underlying prevalence to bleed. So atrial fibrillation is a growing problem. It's associated with greater morbidity and mortality. And you can see here a higher stroke risk for older patients and those with prior stroke or TIA. And 20% of all strokes are AF related. They're very debilitating. Why? Because you're sending clot from the heart to a brain vessel that doesn't want the clot there. So obviously when the clot gets to that area, it shuts down the brain function in that particular area. And again, it's about time. If this is not recognized immediately, your brain function, the muscle, actually the tissue, dies. So hence, it's time is brain. You need to make sure that you get to the ER as soon as possible as when these type of symptoms develop. But if you're on a blood thinner and say, well, fine, I'm just going to take the blood thinner because I know I have AFib and I don't want to have the risk of stroke, well, this is unfortunately what you may also find. Anticoagulant therapy carries a risk of intracerebral hemorrhage or death. Naturally, if you're on a blood thinner and say you have hypertension and your blood pressure is uncontrolled and you have a small blood vessel in your brain that has a little bleed, if you're on a blood thinner, that little bleed becomes catastrophic. So what do we use to judge if a person who has atrial fibrillation should be on a blood thinner? Well, rather than reading you all these numbers and points, there is a phrase we use, an acronym actually, called CHADS-VASc. Basically, that means patients with heart failure, hypertension, an age of 65 or 75 with 2 points, diabetes, prior stroke, vascular disease, which means carotid artery disease, aortic disease, or a prior heart attack, and a gender of female. I know it sounds like a lot of things I just mentioned, but those are the risk factors that every doctor who treats patients with atrial fibrillation have to go through mentally when you walk in the door. So whenever a patient sits down with me who has AFib, I go through that in my brain and make sure that I have a number calculated, and hence then I can predict their yearly stroke risk, obviously based on the points that are allotted to their conditions. So we know that warfarin or Coumadin is extremely effective. It works. I have thousands of patients that in the past 10 years that have been taking Coumadin without a problems, but the truth is, a lot of patients that I have actually had issues with it, and it's not because of bleeding. Sometimes they don't take the right amount of dose. Sometimes they eat the wrong foods, which makes their Coumadin or warfarin not really work. So if you see the slide here, 44% of patients who are taking Coumadin or warfarin have bleeding events associated with too high of an INR, which is where we measure it. 48% of patients are too low. And I'm going to tell you something, 2 to 3 is a number we utilize for INR checks or the check for the Coumadin levels. I can't tell you how many patients come to the ER with a stroke because their INR is 1.9. So being 1.9 is not close enough. You really do need to be in the 2 to 3 range for this drug to work. So there's a lot of challenges, even with the new medications like I mentioned, the Xareltos, the Eliquises, the Pradaxes of the world. The reason why, it's cost. And these are blood thinning medications. So you can still have the side effects of warfarin and Coumadin with the bleeding risks. So it's not like it's just a less intense medication. It's an equal intensity. It's just that it's not needed to adjust your food or your dietary habits, like I said, with the food, or check your levels. These are important facets of why these medications are so popular. So again, we know that AF is a growing problem associated with a greater morbidity and mortality, 5 times increased risk of stroke, and 90% of clots formed in the left atrium, especially during atrial fibrillation, are from the left atrial appendage. The current treatment is usually a blood thinner. But again, we have a lot of patients who decide to stop taking the blood thinners because of either perceived bleeding or fear of bleeding or actual bleeding. So at this point, I'm going to show you a new therapy that's actually not too new. It's been around for at least 8 years now, but it's something that we are doing actively here for patients who have atrial fibrillation who cannot successfully take a blood thinner long term. This device is called the Watchman Flex. And this is not the actual size, it's a lot smaller, so don't worry. It's not this big going in you. But it is basically a mesh metallic structure with a wrap on top of it. And how I describe this device to patients is basically if you have a left atrial appendage in your heart, which is like the appendix of the heart, this acts as a cork. It literally can be placed into the appendage and cork it off, just like you would do a bottle of wine. And over time, your body will then consider this part of it and absorb it, and it actually will be a permanent structure in the heart. And these diagrams are showing you the safety and procedural performance of the device. And this device that's being showed currently is the Watchman Flex, which was just released in the last 6 months, which we are currently using at Boulder Heart. This is how we deploy the device. We put a sheath through the femoral vein. We then get to the atrial septal and puncture across. You do not feel this, and that hole will cover itself up once we remove the sheath. A wire is placed into the appendage of the heart. We then replace this with an actual Watchman sheath, and that's called a pigtail catheter. And with this, we will advance the catheter after we identify the morphology of the appendage. And you see these interesting names, broccoli, chicken wing. All these are terms that we describe how an appendage may look, because not every person is the same. We inject some contrast to make sure we know what the depth of the size of the appendage is. We then pull the pigtail back and advance the Watchman device. It becomes a ball, and then gently, I'll push it in and deploy it. If I don't like the size or the location, I'll retrieve it and try it again. Putting it a little bit deeper, maybe a little more shallow, depending on how the appendage looks. and then we'll redeploy it again. At this point, we can still take it out of the body if we like. We then check our measurements. We pull the device, try to get it, actually remove it just by force to make sure that it's in place. And that's called the tug test that you can see right there. We make sure the size is appropriate, and we have our sizing chart, which is measured against our ultrasound, which is done during the procedure. And at the end, we measure our seal. Let's make sure there's no color around the device. That means that anything can get to the appendage and out. And then finally, we deploy the device. And then there's anchors that are on the device that hook into the tissue of the cardium. And then at this point in time, the device is in place. And over time, as you can see, the heart grows tissue over the device and absorbs it. And we'll continue on here. So the Watchman has been studied extensively over the last 10 years. There's a 72% reduction of bleeding post-procedure on patients who have gotten the Watchman versus patients who are on chronic blood thinners. So this results in a significant reduction in disabling strokes. The category of who can get a Watchman. So this is important. I can tell you every week I see approximately 10 to 15 consults in the office for Watchman, and only about a fraction of those patients get it. And why is that? Because a lot of the patients are like on the left side of the screen, people who can take oral anticoagulation but don't want to. And currently, that is not the indication to get this device. This device is indicated for patients who cannot tolerate long-term blood thinners. You do need to be on a blood thinner for 45 days after a Watchman implant, so patients who absolutely cannot even look at a blood thinner shouldn't be getting this device as well. It is important that we actually have a solid conversation about this in the office prior to saying, I can or cannot get it. Because again, there's a lot of patients who I think deserve the opportunity to get something like this versus patients, again, who probably don't need it and just need to stay on their blood thinner. So this is a conversation to have with your doctor in the office before, obviously, you make any firm decisions about yes or no about blood thinners or getting this procedure. So let's moving on for the sake of time. I'm going to talk about a second major source of stroke, but not necessarily in an older population, but one that seems to strike a lot younger patient population. This is called patent foramen ovale, so PFO. A PFO is a persistent, usually flap-like opening between the atrial septum primum and secundum at the location of the fossa ovalis. A lot of fancy words there. Basically, it's a little bit of a door that's sitting in the top part of your heart between the two chambers of the right and left atrium. It's basically something that was formed when you were born, when we were all born. And usually after birth, the pulmonary circulation comes into play, and then it actually closes the foramen ovale. However, in 20% of the human race, there is some remnant or opening called a PFO in the population. So it's not like it's 1% of the human race, it's 20%. So there's a lot of people out there that have this. So what it really is, like I said, a persistent flap-like opening. And again, at birth, it usually closes. But again, in the people that it doesn't close, that's fine. It's something that a lot of people live with no issues. However, the association between PFO and cryptogenic stroke, and that cryptogenic sounds kind of like, well, that's a real weird term. Well, that term just basically means a stroke from an unknown etiology. It's like we don't know where the stroke came from. You know you had it, but we just can't figure it out. So hence the PFO came into play here, because looking for a source, we saw a number of patients who had PFOs, who had strokes, but no other risk factors. And that's when the research developed about, could the PFO be a responsible party in this situation? So in patients with a cryptogenic stroke, prevalence of PFO ranges from 40 to 60%. So evidence is mounting to seek a better alternative than just prescribing antiplatelet medications like aspirin and Plavix. So cryptogenic stroke, again, an obscure or unknown origin for the stroke. And again, we're still looking at other causes, and 1/3 of ischemic strokes are considered cryptogenic. So again, with cryptogenic strokes, nearly 700,000 in the US, 80 to 85 of them are ischemic, which means a clot has gone to the brain or some calcium or something has moved to the brain. 40 to 60% of these PFOs among cryptogenic strokes, and 100,000 strokes a year with PFO as the only identified potential etiology. So talking about these numbers, you're like, well, heck, if I got a PFO, should I be worried? No. The PFO may be a player, may be an innocent bystander. We're just seeing the evidence as the years, in the last 5 years especially, accrue, that maybe we're seeing more than just an association. So why does a PFO, how can it play a part? Well, because it's a flap between the two chambers, between the left and the right side, and you can see on the slide, the right atrium to the left atrium, what can happen is on that flap, that door flap, you can see sometimes development of microemboli or clot development because there's some stagnation of flow between the two chambers. So the truth is, if that's the case, where we see some clot there in the chambers, and it may be on the PFO, well, why aren't we actively trying to close more of them? Well, that's because historically a number of clinical trials had not shown a major benefit from PFO closure. And again, a number of these studies had signals of a positive benefit with device utilization. So in the last 7 years, in the last 8 years actually, we're seeing high quality clinical trials in major medical journals being published, which are actually showing that there is actually a trend to benefit in certain patient populations by performing a closure of their PFO. And usually when I mean closure of the PFO, it's not an open heart surgical closure, but rather a minimally invasive procedure that goes through the groin, which we'll show you the video shortly. So in these trials, there is actual data now accruing saying that percutaneous PFO closure does not reduce the risk of subsequent events in patients with cryptogenic thromboembolism. However, we're seeing that there's trends that are moving in that direction. And then we're seeing other trials that have come out recently in the last, say, 10 years that are also pointing to that there are actual benefits potentially of closing these patients versus just medical therapy. So in this trial, in patients with cryptogenic stroke, percutaneous PFO closure does not appear to prevent recurrent stroke, although secondary analyses suggest possible efficacy. Again, it's not a slam dunk to close these PFOs with the device. However, there are now more points pointing towards saying, could there be benefit potentially in certain patient populations? More trials that have come through again. And in the closed trial, there was a randomization of 663 patients to PFO closure or antiplatelet therapy or oral anticoagulation. They see here in the data that 3 strokes occurred in the anticoagulation arm, but there was inadequate statistical power to compare these outcomes with the other 2 groups. In the conclusion of the trial, amongst patients 16 to 60 years of age who had a recent cryptogenic stroke attributed to PFO with an associated atrial septal aneurysm or large intra-atrial shunt, the rate of stroke was lower with PFO closure, plus long-term antiplatelet therapy than with antiplatelet therapy alone. So this was a pretty big sea change in how we were doing things, because to be honest, we didn't have enough data to say that putting someone on a potent blood thinner for a stroke caused by PFO was the right thing to do because the risk of bleeding was real. We didn't have enough data to say putting a device in there was the best thing to do. So what did we do normally? We put them on Plavix and aspirin, which are weaker blood thinners. But now we were getting data that actually said, you know what? If you put the device in this certain patient population with the aspirin and Plavix, you will actually reduce your rate of strokes compared to just putting them on medications alone. The REDUCE trial was another trial that utilized a Gore Helix septal occluder device. What they were seeing is that PFO closure was associated with significantly lower incidence of clinical ischemic stroke at 1.4% versus 5.4%, basically against medical therapy, antiplatelet agents. So this is important because now we're seeing, again, more trials that are coming out in the positive for PFO closure. As time goes on, if you can see here, back in 2000, how things had started and how things had just migrated, you could see the lengths of the trials initially. There was about 3 or 5 trials in the early 2000s. These trials were not positive, so hence we stopped really doing much about PFO closure. And then you see around 2012, they picked up steam again because people started doing secondary analysis of these trials and said, you know what, let's give it a shot with better devices. Let's see if this makes a difference. And now you can see how many FDA approval devices there are right now in the market, which is pretty amazing that we actually have these devices to utilize in this current age. And how do we put this device in? Well, this is just a rough diagram to show you how an Amplatz septal occluder device by Abbott is put in. And I will show you the video of this device because this is the device that's been on the market the longest and has the longest approval track record. And we're going to show you that video right now. So basically, this video is showing you how clot from whatever source in the body can get into the heart. And basically, instead of getting out of the heart, it gets through that little, see that little trap door? That was the PFO. And now the clot is on the left side of the heart. And what that clot ends up doing, it gets shifted out and goes where we really don't want it to go, causing a major stroke. So how a PFO closure device is performed, we don't have to make a hole in the heart. The hole is there. We go across with the catheter, release the first disc of the device, pull it back across the left atrium, and then place the right side of the disc. It's like a hamburger bun in that situation. And then we deploy it. This is a quick procedure, usually an hour in length of time. Patients then stay one night in the hospital and are discharged the next day. And we can exit out of the video. So where do we go from here? Every patient who has a history of TIA or CVA needs a professional neurologic evaluation. If a PFO is found, alternate reasons for stroke need to be evaluated first. Atrial fibrillation, carotid artery disease, somewhere else. And why am I saying that? As someone who implants these devices, because again, it's easy to perform these procedures, but it's not always the right answer. So if there is a situation where we have a patient that has a potential for one of these other causes, the likelihood that these other causes are more, should we say, prevalent, or should be more likely to cause the situation is higher. Because if you're 80 years old and you are asking me to close your PFO, I'll have to be honest with you. You've lived with your PFO for 80 years. Why did it cause a problem at this point? So hence the guidelines have understood the dilemma that clinicians have and that what patients have. Recently, we've seen more increased data from, or more feedback from the committees that make guidelines to say that actually up to the age of 60, we can consider PFO closure as being a legitimate source of the emboli, or the source of the PFO being the source of the stroke. Now 60 and over, again, I still believe that other sources like carotid artery disease, atrial fibrillation, something else may be more prevalent. And I'll be honest, even at 60, if you came to my office at 58 years old and had a stroke from potentially a PFO, I would still want to make sure we've ruled out any other source before we decide to close you and put a device in. Because again, once the device is in, it's in. And the last thing we wanted to do is have any complication associated with putting a device in when really the stroke was caused by an alternate etiology. So future directions. There's a lot of controversy about, well, why do we put a device in? Why don't we just put people on Coumadin or the Xarelto and Eliquis of the world? So the trials are ongoing currently. In a 20-year-old who just had a stroke, I can tell you right now from firsthand knowledge, no 20-year-old wants to be on a lifelong form of blood thinners if they can get a closure device. But that being said, we should still be evidence-based. And that is really important to make sure that if we find a blood thinner is better than putting a device in, well, then that should be the therapy. So at this point in time, though, unfortunately, we don't have the firm data, and we know the risks associated with being on long-term blood thinners, as I previously mentioned. So stroke can come from a number of different avenues. Therapies to reduce stroke burden are essential to reduce the morbidity and mortality associated with this condition. I'm really excited to be a part of the ongoing technological revolution in stroke therapy. I feel that it's amazing we can do things for patients now that 20 years ago we could not. However, again, we need to temper our enthusiasm for the right procedure for the right patient or the right therapy for the right patient, even if it means no procedure. And with that, I'd like to say thank you, and we should open the floor to questions.
Thank you, doctors. It was very informative, and thank you for all of that. And we're going to just jump right into the questions. I'm not sure which of you guys want to take that, so I'll just leave it to you as we go along. The first question is, I am on warfarin due to 2 previous PEs. I plan to keep on taking warfarin far into the future. Will warfarin reduce my risk for strokes?
Well, the answer for that is, will it reduce the risk of strokes? Absolutely. For ischemic strokes, no doubt. Being on long-term blood thinners, we do know as patients get older, there's always a risk that bleeding risks do increase. However, for ischemic strokes, being on warfarin is critical, but also for this patient's history of pulmonary embolism, if they've had more than 1 lung clot, they may have something called a hypercoagulable situation where they develop clots faster than most people. So this is a no-brainer. If someone has anything like that where they develop clots in their legs or lungs more than once, you have to be on a blood thinner for the rest of your life.
Okay, good to know. Are there specific things to distinguish an ischemic stroke from a migraine with aura that includes vision and speech impairments?
Yes, that is a common question, and it comes up a lot in the emergency room. And what happens is we hear the story, and the devil is in the details. So in general, if someone has what we call positive phenomena, they're experiencing bright lights, kaleidoscope in their vision out to the side, it comes on gradually, it spreads, and then lasts about 15 or 20 minutes and can be associated with some tingling or even speech impairment, followed by a headache with throbbing characteristics, light sensitivity, sound sensitivity. That is more likely a migraine than anything else, particularly in anybody under the age of 60. And a stroke has what we refer to as negative symptoms, a loss of function most typically. So you might lose your vision instead of having a kaleidoscope of vision or flashing lights in your vision, or a tingling can occur with either, but if your arm goes completely limp abruptly, then that's more likely a stroke than a migraine. Migraine tends to come on over 20, 30 minutes. Strokes tend to come on over just a few minutes. That's the general overview. So usually we can tell the difference pretty reliably.
Thank you. While sleeping, I was awakened by lightning bolts and buzzing in my head. Is that a stroke?
Well, typically, no. Stroke can present with abrupt pain, so if there are no other deficits, it's not likely stroke, it's likely some headache syndrome. The caveat to that is when we're not sure, we say, come on in and see us, let's talk about it, let's talk about your individual risk factors and see if we ought to do a thorough investigation, because individuals who carry many risk factors, we might very well feel we need to do something. Other people, it would just be a good dose of reassurance.
Perfect. Are there foods to be avoided if a person is on warfarin?
Right, so it's basically, when we say avoid foods, we don't like to tell them they can't eat something, but leafy green vegetables, alcohol, anything that may affect the liver, these are things that can actually alter your warfarin Coumadin levels. There are certain medications, and again, it's just the issue of knowing what you're on. Warfarin and Coumadin work great if you know what else is going in your body, and I think that's the main reason. The commercials that we see on TV, they show people eating a whole tub full of salad because they want to show that, hey, you can eat whatever you want and not worry about changing your dosing of your Coumadin and warfarin. This is important, though, for anybody who takes warfarin and Coumadin. Don't just look at food. Also, talk to your doctor or pharmacist about what interactions your other medications have with it, because there may be adjustments of your levels that you don't know about that other medications are causing it.
Thank you. You just mentioned possible complications of a PFO, but you didn't say what those complications are. Can you explain?
Right, so if we go in to do a procedure, I always explain to a patient, if we're doing a procedure, the negatives of the complications should always be extremely low versus the positives of the procedure. It should never be equivalent, and it should never be the negatives of the procedure are higher, but there's always a risk of a complication doing any procedure. So when we go into the heart with a catheter and putting a device across the septum, we're putting a foreign object in the heart which may stimulate arrhythmias. That device could actually erode the septum, and these are from more than 10, 12 years ago of the older devices, but it can still happen where the device can erode the septum. It can get infected, which would lead then to an open heart procedure to remove it. So these are all factors that play in before we decide to do any of these closure devices. So that's why I always remind everyone, it's not as simple as the video looks. We are putting a device in your heart, and that has real consequences. So we better have a really good reason to do it.
Thank you. Is low-dose aspirin still considered useful in preventing a stroke?
Sure. The story with low-dose aspirin is a story of what we call primary prevention versus secondary prevention. Current guidelines suggest that just taking an aspirin alone isn't a recommendation across the board. There have been several studies that have looked into this. So we tell people, if you take a daily aspirin, you will decrease your risk of stroke. You will decrease your risk of heart attack. That's factual. But it turns out for most individuals who've never had a heart attack or a stroke, doing that alone actually increases your risk of bleeding just enough that those potential benefits are outweighed by the potential risk of bleeding. This is across an entire population. Keep in mind, statistics don't apply to a single individual. It's the reason the Heart Association and Stroke Association don't say across the board at any given age, everyone must take aspirin. The opposite is true for if you have a heart attack or stroke. Universally, we say you should take aspirin because that has been shown to decrease your risk of heart attack and stroke. It's a tricky balance, but as of now, data does not suggest everyone should take aspirin at some given age. You need to have some risk factor like a previous TIA, coronary artery disease, strokes, before we would say for sure take an aspirin. But stay tuned, that may change. There are lots of studies frequently that modify the use of these medicines like aspirin.
Thank you. Can sepsis, which I contracted 5 months ago, be a negative factor in having a stroke?
What did you say again? I missed the question.
Can sepsis, which this person contracted 5 months ago, be a negative factor in having a stroke?
I would say in general it could be, but at this point, most of that risk factor is gone. During the sepsis syndrome, you're at increased risk of clotting and blood pressure problems. But this far out, unless there's some permanent damage that came about, such as injuring your heart valves or creating disease within the blood vessels in the brain, most of that risk is probably gone.
What are the mesh elements made of?
Well, the mesh elements can be made of basically nitinol, which is, you have nickel titanium, and then you have either Gore-Tex fabric, which is one of the the Gore-Tex device. And again, going into the manufacturer, it's hard to tell you exactly the makeup of their particular fabric without actually going to their proprietary website. So I would actually refer anybody who's interested in the intricacies of the makeup of these devices. So instead of telling you, well, what particular matter it is, either go to the Gore website or the Abbott website to actually look at those devices, the Abbott PFO, to see what the exact makeup of the face of the device is. So it would probably be a better explanation than trying to tell you how each device is broken down, because there's nuances to each device. They're not universal in the mesh covering of their face.
How can you find out if you're in the 20% of the population with PFO?
Well, the truth is the only way to really find out if you have a PFO is to actually have an echocardiogram, which is an ultrasound of the heart, not the EKG, and do something called a bubble study, which again, you don't have to have. This is just something that if you were determined to know about a PFO, that would be the first test, the safest test to really identify if you had the PFO. But it is something that, again, I don't want people to get paranoid. It's something that we want to keep everyone understanding that if 20% of the human race has it, don't worry. This is not something that would be a red flag that you are definitely going to have a stroke in the future. It's one of those things where it is an association. We have seen it happen, but I have a lot of young patients who have PFOs who do not have strokes. So I'll just reassure everyone, this is not something I would seek out a cardiologist for just to find out about a PFO.
This will be our last question of the evening, fellas. It'll be, how are hospitals rated for emergency stroke care?
We have designations depending on the organizations, but there are generally stroke centers called comprehensive stroke centers. Those are places that have generally research associated with them, high volumes, and lots of interventional capabilities. We don't do that at Boulder Community. We are called a primary stroke center, and we have a certification from the American Heart Association, Stroke Association, and the Joint Commission on Hospital Accreditation. So that information is available through typically our BCH website. But within this region, there are many primary stroke centers. That means we are ready to assess you immediately, give you the clot-busting drug if needed, do the appropriate diagnostic studies to get started. And if you happen to need an intervention, then we would put you either on a helicopter or an ambulance and fly you to Swedish Hospital quite quickly. And they are the ones that offer and partner with us on those interventional techniques. So those are the main separations.